Hello, my name is Kathleen Yao and my partner Annie Bode, and we are presenting our project for Nursing 707 on methodology and the conceptual frameworks of our capstone project, which is the implementation of a fertility preservation program. The purpose of our capstone project is to develop and implement a fertility preservation program for newly diagnosed female patients prior to gonadotoxic or cancer treatment. The aims of our project are twofold. One is to educate healthcare providers regarding the development of new reproductive fertility preservation methods available. And the healthcare providers are not only specialties like oncology, but they may include generalists such as family physicians and internists to basically acknowledge and educate them that fertility preservation methods are out there. A second aim is to evaluate patient satisfaction and informed decision making in the fertility preservation care options and the consult itself. Our clinical question has been revised over the past, I would say, year and a half, and we have solidified our PICO question to state the following. Among recently diagnosed female oncology patients in their reproductive years, does fertility preservation information and a decision aid provided prior to the initiation of cancer treatment as compared with those who receive fertility preservation information without a decision aid improve patient satisfaction with informed decision making regarding fertility preservation care options. And I've italicized patient satisfaction because we will be evaluating three outcomes in the whole of patient satisfaction. These would include fertility preservation knowledge, satisfaction with the overall fertility preservation consult, and then lastly, decisional regret.
And we chose the Iowa model for our evidence-based conceptual framework. We chose the Iowa model because it seemed to fit perfectly with what we were doing. The steps are the selection of the topic and then forming a team, which we had done early on in our program here at Heartland in terms of planning for how we wanted our fertility preservation program to be formed. And then we did the evidence retrieval, grading the strength of the evidence, and then developing the evidence-based standard that we wanted to work from. The next two steps that we will be working on are implementing the practice and then evaluating. Okay, now how we used the model to guide our program development was looking at the problem-focused triggers first, and that was centering on the lack of interdisciplinary communication between reproductive medicine and the oncologist, and the lack of referrals, the lack of timely referrals prior to the patient starting the cancer treatment, which caused the infertility. The knowledge-focused triggers include the new technology that's available now in terms of freezing gametes and the ability to do a much better job with fertility preservation that needs to be disseminated to healthcare providers, general practice providers, as well as oncologists, to cancer patients, and then to the general public. The guidelines that we used were the American Society of Clinical Oncologists. They had put out guidelines in 2006 recommending that all patients in childbearing years be referred for at least information about fertility preservation, and also the American College of Gynecologists guidelines. The process, which I just spoke to, included the literature search with review and synthesis, and then validating that we had an adequate research base to work from. And then our next step will be to pilot the practice change. and then we'll continue to evaluate the quality of care. If the pilot will make the needed changes, if the pilot shows us that we need to make changes, and then we'll institute the program, and then continue to analyze and monitor the data.
A second framework that we have looked to in developing our capstone project is the conceptual framework by Nagel et al., published in 2009, taking a multidisciplinary approach to fertility preservation for cancer patients. Here in this graph, you have the cancer patient kind of at the center of everything, and then you have specific entities such as the medical team, including ourselves, the nursing staff, oncologists, the reproductive endocrinologist, and the andrology or the IVF lab. Then you have risk management entities such as legal, ethical, and government regulations in providing fertility preservation care. And then you have patient support. Here they have specific ones listed such as Fertile Future, Help a Child Smile, social work, nursing. Specifically for our location, we might include psychosocial support from Omaha Integrative Care for Fertility or other additional mental health therapists. There's also Live Strong Fertility, which provides financial support for the patient in order to proceed with fertility preservation options such as egg freezing or embryo freezing. And then lastly, you have the research fundamental question, which would be attuned to our current PICO question and what we could do to help implement the fertility preservation program and evaluate it. Aside from the research question, you have branching off into different trees of patient-centered research, quality of care research, scientific community research, and then you have the female and male patient there. And previous classes such as health policy, and then this current class that we're in evaluating quality and improvement, we've looked at kind of the microsystems, the mesosystems, and the macrosystems that can help implement fertility preservation care not only to the patient, but to perhaps make it standardized care locally at the state level or even at the national level. For our capstone project, the design is a pilot survey. It will be a feasibility study here at Heartland Center. The intervention will be the web-based decision aid. The subjects will be the newly diagnosed female cancer patient that has been referred to our office, who is in the process of decision making regarding fertility preservation care. And because we have a fairly low population of these types of patients, we may predict to get possibly 3 to 5 during the time of our data collection. This setting will be here at Heartland Center for Reproductive Medicine at the time of the initial consultation regarding fertility preservation methods and options, and the intervention will be provided at the end of the consult with the reproductive endocrinologist to kind of evaluate how the decision aid helped the patient with the overall patient satisfaction of the consult. And again, the tools and measures that we have decided to evaluate for our specific patients would be utilization of the PROACT survey, which was published by Balthazar in 2013. This is regarding to fertility preservation knowledge. This includes a 20-item true and false questionnaire to evaluate basic FP knowledge. Now, in discussion with our advisor, Dr. Twiss, it was recommended that perhaps true and false may not be the best evaluation of patient knowledge, but perhaps rewording the questions to evaluate my knowledge prior to the consult was this. And then reevaluating it, that restating the question and stating that my knowledge was enhanced by the FP consult. So we're currently working on that at this moment. A second evaluation tool is to measure the outcome of overall satisfaction with the FP consult, and that was published by Bastings et al. In 2014. And this includes, in one part of the evaluation tool, assessing the satisfaction, and this is more of a free response portion of the evaluation, so we may utilize that in helping create our overall evaluation tool. And Annie will discuss the last evaluation tool, which would be in regards to evaluating decisional regret, and then discuss the implementation plan.
And then in terms of the decision regret scale, that is a simple scale with 5 questions on a Likert scoring scale, talking about their confidence with decision making and their satisfaction with decision making. So after looking at both knowledge and satisfaction and their decision confidence, we will, as I stated just previously, pilot and evaluate the pilot program, then implement the program, and then continue to analyze and monitor.
This is a timeline of our capstone project, and we have demonstrated this pictorially using a Gantt chart. For this semester in Nursing 707 and Nursing 702, we have made strides in trying to solidify the framework and also moving our ideas of fertility preservation more into general practice. So first of all, we have examined the outcome measurement tools and have narrowed those down to 3 different tools. Again, looking at fertility preservation knowledge, also the overall satisfaction with the fertility preservation consult, and then thirdly, the decisional regret. We also have attempted to disseminate the idea of fertility preservation care into the general public, so looking at the different systems of quality improvement. So we have tried to just inform the general public, for instance, at the Omaha Women's Conference held by the Olson Women's Center that targets about 300 women around the state, to notify them of different services such as fertility preservation care. At the state level, we have joined the programming committee for the annual NC2, or the National Cancer Coalition Conference, to have fertility preservation be a type of programming for next year's conference held in April. We have revised and have completed a literature review to help focus our previous 2 PICO statements into one formalized PICO statement, assessing, again, the decision aid, and then also looking at patient satisfaction overall. We also have looked at different frameworks. So in the portion of translation of evidence into practice plan, we have utilized the Iowa model of evidence-based practice to promote quality care, as well as that conceptual framework in incorporating a multidisciplinary approach to fertility preservation by Nagel into our capstone project. And then lastly, we are currently working on completion of the final version of our written proposal so that we can move and forge ahead next semester with creating the intervention.
So in summary, the Iowa model for evidence-based practice and the Nagel conceptual framework helped us in our project to focus on the patient needs and the unmet gap in care for cancer survivors, looking at the scientific research and also working within the multidisciplinary team to provide the improved patient care. the development of the methods of our proposal focused on program changes around an organized structure to explore the gaps in current care and base the program changes within the new reproductive technology and the current research, as well as the American Society of Clinical Oncologists recommendations for fertility preservations for newly diagnosed cancer patients.